Good evening and welcome. You're watching Science, Health, and Healing with Dr. Majid Ali. Good evening, doctor. It's good to see you.
Good evening, Richard. Nice to be with you.
And it's good to be with you. My name is Richard Speziali. Dr. Ali, when we did the first of this series of programs focusing on COVID-19, we did the first of them in February, late February. And we spoke about your book on the 1918 global flu pandemic. And you had said that you were afraid history was about to repeat itself. And unfortunately, you were largely right about that. So right now, it's the end of May. We have just surpassed 100,000 deaths attributed to the COVID-19 virus in the United States. What lessons can we learn from the 1918 pandemic, particularly in the second wave of the pandemic, one that has been predicted likely to happen here? And how do you feel about that in light of all the news pictures we've been seeing of the country reopening, crowded swimming pools, crowded restaurants, crowded bars?
Richard, first I have to thank you because this is a truly beautiful question because the answer is going to be useful and revealing. I think in matters of epidemics and more so pandemics like this, the essential lesson for me as a physician is that matters of health for people are their personal matters. They are not matters of public health policymakers or politicians. And COVID-19 gives you the most elegant answer to this question. And to really understand this question, I find a very sharp contrast. CDC in the United States, which keeps the statistics, revealed this, and President Trump announced it, that as an average, 81,000 Americans lost their lives every 3 years in the last 30 years of record. 27,000 every year, that comes to 81,000 every 3 years. Now we have 100,000 lives lost, and rightfully, America is mourning. Rightfully, the consequences and personal hurt for the people who lost their lives, people who are left behind, the businesses which are closed, the businesses which are predicted that they may not actually recover long term from this. I think you can trace it directly with a clear understanding of the one central fact of 1918 Spanish flu pandemic, which killed, by very good records, we were in American World War I, 75 to 100 million people worldwide. It's my estimate that by the time in the next 30 or 40 years, COVID-19 can be considered to have played out, the number worldwide, my sense is going to exceed 10 million people, and it may be substantially larger. So what is the main message that we should learn? The main message, Richard, is every time you hear a program on television or radio about seasonal flu epidemics or the major flu pandemics like the one that we are in, COVID-19, the speaker immediately talks about the people who have underlying conditions who died. And then people make a distinction between people who die of flu virus or people who die with flu virus. When the initial data came around about this COVID-19 in the United States, it is true that the tests were new. The virus was new, but the tests used to detect this virus were also new. But at that time, there was an understatement of people, underreporting of people who got infected. But because of the way the hospital practices are, when somebody is hospitalized with the clinical symptom complexes of COVID, it is very common for nurses or emergency room staff to put COVID-19 in the diagnostic box of that admission sheet. Now, throughout that time in the hospitalization, wherever the patient moves from one ICU to another ICU or other areas of treatment in the hospital, one nurse who transfers the patient would announce to the patient, this is COVID-19 patient. So when this patient goes on to die, the tendency is to say this is a COVID-19 death. In reality, as people recognize, there were the deaths of underlying conditions, and immediately we are told the number one underlying condition is diabetes. The number two underlying condition is asthma. The number three underlying condition is heart failure. And then you go on to autoimmune problems. So we've had flu vaccines for 70, 80 years. In spite of those vaccines, we are losing 81,000 people every 3 years. We've been trying to develop antiviral drugs, and we've had some success, for example, for AIDS, okay? But we haven't had any success for flu viruses. Richard, I can tell you that my colleagues and I, in our practice, we've had patients who were test positive, COVID-19 test positive. We have had yet the first patient in our practice to have to go to the hospital. We've never had a patient so far who was actually had to be put on ventilators. Now, these patients, what did they do? No, they did not take any specific antiviral therapy, natural therapy, or drugs, or vaccines, or anything else. They were people who had chronic diseases before. It could be diabetes, it could be asthma, it could have been immune problems, rheumatoid arthritis. But these people had learned to use natural therapies, sleep well, make sure they don't get dehydrated in infection, make sure their bowel transit time is good, their bowel habits are good, they're not all clogged up in this, their digestive tract is working. And of course, they were not terrorized by this aspect of this. So a large body of data tells us that if people can learn to take care of themselves, we need not be thrown into a panic. Every time, one major error was that people who were reporting the data or who were counseling the politicians, government officials, unfortunately, they made bad judgment call. I'll give you one which is glaring. Governor Cuomo of New York, by administrative fiat, said that COVID-19 blood test positive or swab test positive people, they would be allowed to be admitted in nursing home and senior citizens home. Within 24 hours, there were more than 4,000 deaths. That is one example where a politician, a state governor, did not even know where to find the right medical experts to advise him, who had a lot of experience with this. So I believe that a lot of the errors which happened, they happened because of judgment calls, bad judgment calls. And first, we doctors did not prepare them that they are going to be yearly. Now there is going to be a COVID-20 next year or this fall. Dr. Fauci has already predicted that there is going to be a second wave of COVID-19, probably in this coming September or so. I want to take a larger view of this problem. I think viruses have coexisted with us.
Dr. Ali, can you hear me? Because I have lost your voice. Can you hear me? Dr. Ali, can you hear me? Is it my computer? No, it's not. Okay. Dr. Ali, hello. I cannot hear you. I cannot hear you. Can you move your mouse? No, I still can't hear you. Damn. What's going on? Your voice just stopped in mid-sentence. Hang on. Say something again. It came. Okay,
Yes.
it came back. So I'm gonna. Okay.
Okay, device is back. But what I could do is I could ask one of our staff members to come, Cynthia, to come in to help us if this happens again.
All right. Well, I think it's okay now. So let's just
Okay, that's
go
fine.
with this.
That's fine.
So
So the main thought was people have to recognize that their health is their responsibility first and foremost. They need to have authentic information. They need to be prepared for simple things. There is one other thing that I want to mention, which we can bring up in discussion later on. There is a community of people from northern Pakistan who settled about 2 generations ago in northern New Jersey. They lost 2 young men, 2 brothers, to COVID-19 in the early days of COVID coming to New Jersey and United States. That galvanized their community and shocked that community. They recognize that we do not have effective drugs against flu in America. They also recognize that people were getting flu in spite of the vaccination that they had. They came to the conclusion that they wanted to try some natural indigenous therapy that their ancestors used to use in Pakistan. For example, ginger-based remedies, ginger tea, ginger bone broth, ginger water. Amazingly, they tell me now that now when their community members get COVID-19, it's not so severe, and usually they clear it within a week or two. So this notion that by being proactive about our health, by having access to authentic information, but not allowing us to be thrown into national panic with some misinterpreted data, I believe that that should be an important part of our approach to this problem going forward.
So let me back up a little and ask you about something you said. Now, you were saying that that most doctors were not making the distinction between dying of the flu or dying of the virus and dying with the flu, ignoring the underlying circumstances. So why do you think that was? And obviously, you think that contributed to the confusion of public policy, public policy makers and politicians and such.
Your listeners and your viewers will appreciate what I'm going to say next.
Okay.
In most American hospitals, when a hospitalized patient goes on and dies, and there is an autopsy done, the death certificate is signed by the pathologist who did the autopsy because he has most information. I will tell you, I served as the chief of pathology in a major metropolitan New York hospital. And I do not recall, and I've checked with my 3 associates, they do not also recall ever putting flu on the death certificate in that box which specifically talks about the primary cause of death. Translation. There is no way that we can just associate the positivity of the test as a proof that the patient lost their life to this. Because coming back to the same thing of underlying causes, if people had, let's say, uncontrolled blood pressure, if people had asthma attack that could not be controlled, if patient had diabetes which was out of control, if the patients were heavily medicated and they were nutritionally deficient or they're immunocompromised, then Richard, that is responsibility of the profession also. If every educational program about COVID type of virus pandemics in our middle schools, in our high schools, in our colleges, in our nursing schools, in medical schools, if this point was emphasized repeatedly and underscored, I believe we could draw much benefits from this approach while we continue to do our work in trying to find new drugs which are effective for viruses, flu viruses, as well as we continue our work on the development of vaccine.
So let me ask you about a very important piece of this puzzle that just seems to be ramping up in this country at last, and that is testing. At first we had no tests, but now there's more and more. There's lots of testing sites open in New York State. So what lab tests are available right now? I myself, I think I related to you, I myself got the swab up the nose test. So what does that consist?
Right. Okay. There are two primary tests available. One is swab up the nose. That picks up the viral particle or the viral genetic material. So that test is the test for the presence of the virus in the area which is sampled specifically. The other viral test is a blood test. That checks and measures the concentration of antibodies that human immune system makes in response to exposure to the virus. And so that is often considered as indicating resistance to the virus. So it is considered as a protective antibody. In clinical pathology, laboratory medicine 101, there is this statement that all antibody tests which are done by reacting the blood sample with the specific antigen to which the antibody is produced, none of them can ever be considered 100% sensitive and 100% specific. The first patient that in New York I tested for the antibody blood test, that report back came as positive. And that patient said, does it mean that I am immune to it? I said, it means that you've been exposed to this virus. It also means that you have been probably exposed to the other viruses which are close cousins to COVID-19 virus. That's exactly what the result showed. The result showed that there are antibodies coded to detectable to COVID-19, but there were also antibodies detectable to COVID-23 and COVID-34 and COVID-229. All flu viruses belong to this large family of viruses. They are called coronaviruses. So my book, which came out in 2006, 14 years ago, I did not use the word corona because corona was not part of the vocabulary at that time. But I described the flu virus that this is a virus which has sharp spikes on its surface, and it uses those spikes to anchor itself when it is on the delicate lining of the nose and the sinuses and the throat and the stomach and so on. And so it was known at that time that 1918 Spanish flu virus was a coronavirus, and it would have the same structure, though the common vernacular about that did not focus on this part of corona. There was always more than one strain of flu viruses in the bodies of people who either are sick with the flu-like symptoms or they're not. And indeed, there is a big issue. What is the number of Americans who by swab tests are positive for flu virus exposure, and yet they don't have clinical symptoms? And so the general sense is, especially a study coming out of Stanford University on the West Coast, that a larger number of the people who are positive to the swab test, the antigen is called technically antigen, but let's say it's a test specifically for the viral substance. Okay. The general information is that more people who have this test positive do not have any symptoms whatsoever, rather than those people who have symptoms of flu and the test is also positive. So now, if you do both tests, there is another problem. Because in the minds of people, if I have both the viral swab test and the antibody blood test, then that counts for two tests. So unfortunately, when they keep the statistics, they don't separate those two tests. So you get this artifact that you're not specifically saying that we have one positive test or we have both positive tests, and we do not make a distinction of what is the significance or the clinical meaning of those tests.
So let me ask you this
Hopefully in
question.
future it will be resolved.
Let me ask you this question. Who should consider each test? And I'll give you specific examples. Let's say, for example, I'm an older person, I'm at risk, and I'm just concerned that I should get the test. And the other example is a younger person, but who's maybe had a sore throat or some kind of a health issue, thinks they may have gotten the virus. Would one test or the other be more appropriate for either?
Well, the first test that I would do for both, for two different reasons, would be the swab, the virus test.
Mm-hmm.
Now, when you do this test, there's always a satisfaction that you are now aware of the results. And if the result is positive, it usually brings on tremendous stress for the patient. Now, if the test is false negative, then the doctors are going to look at the temperature. That's why people, at the airport or White House, when people go there, they have a skin temperature test. Okay, so people are realizing that simple temperature taking is a very good, valuable piece of information. Now, the test also help you define the level of care which is needed for a particular person. So, for example, if somebody has flu symptoms and you do the test, the swab test, and the test is back negative, well, it's wonderful because it's very reassuring for the patient and the family. You can always
reassuring for the moment. Reassuring for the moment. Now, the thing is, when I got the test, it was like, okay, and I got the results pretty quickly within 5 days. But then I was thinking, okay, I am not positive for COVID-19, or at least I wasn't on Sunday. So, I mean, that's the thing. So that was 4 weeks ago. So I wasn't then, but that's it's a temporary. And I'm tempted to, take more tests at a regular interval just to know.
I think that's a very reasonable thing in a city like New York, and I know that you are running a television station. There are a lot of people there going in and out. So, information, Richard, is not bad. What is bad sometimes in clinical medical practice is the significance we attach to the information of laboratory tests. For example, if the patient is really well informed, then frankly, why not do the test? Because the test does, since you said that you have some risk factors which would be considered risk factors for this, doing the test for you actually, if it comes back negative, you are very, very happy because that means that the risk factors that you have, in spite of that, your immune system is strong enough so the test is not positive. Okay, it may be that you have not been exposed to the virus, but it is also positive that your exposure to the virus, you were able to control the number of replications of the virus in the body. So the viral material has to reach a certain quantity for the test to become positive. Okay, so I think that the downside of that would be that some people who have anxiety states or the panic attacks or depression, or they are taking psychotropic drugs, they may be so weakened by those other factors or their underlying condition that indeed this may be the straw on the camel's back, which really makes a disproportionately large impact, clinical impact. Well, that's not an argument to say no to the information. It only means that now there has to be an effort, Richard, to tell the patient, focus more on all the good things that the patient can do other than drugs. No, I am not opposed to drugs. If somebody says that they want to use Zithromax or hydroxychloroquine, the malaria drug, I think there's a time and a place for it. And I think that in my own clinical judgment, the patient has a higher priority on those things. People can intelligently read about these tests. So some doctor or somebody criticizing some people because they had the test, I think that criticism is uncalled for. After all, it is that individual's life and that person is making a difference. What you can do is, let's say you have a 2-page write-up of this conversation, for example. And so ask them if they would read my write-up about, let's say, 2 pages about interpretation of COVID-19 test, or this program actually. I said that the antibody test can never be considered 100% sensitive, 100% specific in any case.
I was about to ask you why can't it? It seems like there should be to my very simple non-scientific mind, there should be a set number of antibodies that they can count per sample per million, and below this level it's negative, above this level is positive. So why isn't it such a specific determination?
In technical language, there is a term called cross-reactivity. Let's say, and this is a common problem in the hospital blood banks, so we pathologists are generally familiar with it. There are some patients who, when you are cross-matching and finding the blood which is suitable for them, they would give you not only the positive test to the blood group incompatibility, which is AB and O, the 4 major types. But those patients, let's say, who had a type of a pneumonia called viral pneumonia, which they might have had 3 months later, they have antibodies against that virus in their blood. And those antibodies provide a non-specific bridge between the 2 molecules that you are trying to detect. So this kind of a non-specific bridging triggers non-specific reactions. So at that time, the doctors, nurses, clinicians have to come into the picture and examine the patient, listen to the patient, and then decide how to interpret this test. Could it be just flat out false negative? Now, how do you know false negative? Well, you can simply repeat the test. But a good example to understand this problem is the case of Lyme disease. Now, Lyme disease in 1970, when it was the first time the virus was detected, at that time it was very simple. But as more and more people were tested, now we found out that more and more people were sick. They have positive tests, but they actually did not have clinical disease. And the reason is they may have been, it seems like they were exposed to the microbe which causes Lyme disease in past years, because the microbe lives in the tick which live on deers, on the deer hides. So the deers have been around in the United States for a very long time, and also in Europe. So we are being constantly exposed to the material which triggers the body reactions, and that gives you the positive results. But generally, it's a problem that experienced clinicians can manage pretty well. They get an extra sense that this test may not be positive. Let's repeat it after 2 weeks and see what happens, or let's repeat it. If there's an issue that sample has been tampered, or the sample was not drawn properly, or there was a mislabeling in the laboratory, or the laboratorian who was doing the test, there were errors there. Those are simple things. And the pathologists, laboratory professionals know these things. And especially, you can always get a new sample and repeat the test.
Okay, so speaking of tests, now we're seeing an increased number of tests in New York State, around the nation. Many are saying that we should have had the tests earlier and it probably would have saved lives. But how would you rate the COVID-19 testing done so far in the United States?
There are 2 separate issues. One is the technical standards. Were they met? The test material that was being used, was it valid? It was not outdated. The testing conditions were right. So when you come to it, I think the main problem has been that this modeling that they have been using. They've been using the data to model those things. Okay, that's where the error is, because earlier on the tests were not very precise because it was a novel virus. Also because we did not have, it takes a lot of time to develop a test and then apply to a large population and get a certain sense. So there was, in the early stages, there was over-reporting of the positive results. At that time, I'm sorry, I meant under-reporting.
Underreporting.
And as I said earlier on, the number of people who were considered positive, they were being underreported. You know, I made the mistakes, etc. Well, if you over-report them, let's go back. If you over-report the number of people who died and under-report the number of people who were infected, then the mortality rises. And based on that, the statements were made that the killing capacity of COVID-19 may be 80 times as high as the ordinary seasonal flu. And some people went for as far as 100. And remember, they were at that time reporting that the mortality of COVID-19 is going to be around 3%. And the mortality of the seasonal flu was considered as 0.3%. So that's a big difference. That would be a difference of 10, okay, tenfold.
Yes.
So I think that I see more difficulty in the way the data was gathered in the data that was the way it was reported, especially when they reported the data for the viral bodies and they report the data for the viral antibodies, which indicates the patient's status. And so some of them were counted as two tests. And especially when somebody wanted to bold as a bloat that how many people in his province or in his city were tested. Well, if you do both tests, you're doubling up the number of the tests, but you're really not adding any light to the clinical care of the patient. So those were the problems of this. And hopefully going forward, those problems will be resolved.
Yeah, I was going to ask you about that. As you said, there is expected to be a COVID-20, a COVID-21.
Absolutely.
We're going to be dealing with this problem for quite some time.
Yes. Listen, the fact that we have seasonal flu epidemic in most years, and the fact that that virus also has a killing capacity that I mentioned earlier, and the hard numbers kept by CDC are a sizable mortality, 81,000 people every 3 years. Well, that indicates that the viruses are in our environment. So we should not be surprised that our immune system recognizes that one strain of virus or recognizes two different strains of the same virus, the viral species. Flu is a viral species. Flu is actually, you can consider that there are a lot of cousin viruses coming in this category, which are closely related, but they are not identical antigenically. Genetically, they are somewhat different.
Okay, so let me ask you this. Now, it seems like, you talked about average of 81,000 deaths every 3 years. Where were the doctors, where were the public health officials about this death toll that's just been accepted? And you've noted that this has been pretty consistent over the past 25 years.
I hope and I pray that the primary legacy of COVID-19 would be a soulful pursuit of this question, exactly this question. Because I think this is where the potential is. We have been saying forever and ever that people die of underlying conditions. Well, if somebody has diabetes, I will tell you that diabetes is a name given to a condition caused by undetected insulin toxicity, 5, 10, or 15 years. In those years, insulin toxicity is shrinking the patient's brain, and a swelling of the patient's liver. This is common knowledge. This has been known for decades. Okay, so and we have also published our own data, which clearly shows what I've just told you, that, etc. I think that because of the involvement of the public at this scale, because of the involvement and of the politicians and the government public health policy, that there would be scrutiny of what those underlying conditions are, which we say are the real causes of death. And the passage of the virus happens to be just something which coincided. Yes, the virus does cause stress and inflammation, but what turned the balance on the other side and led to the demise of the patient, I think I related my own case in one of your earlier podcasts that in 2001, I myself had flu infection, which put me in an intensive care unit of our hospital for 21 days, 21, 22 days. And that at that time, there was a serious controversy in our hospital because I was working, I had finished 2 years as my terms as my elected president of the staff. So there was more interest in my case among doctors, nurses, administration. And there was controversy whether I should be put on ventilator or not. Fortunately for me, my pulmonologist was a very close friend of mine. He was very, very aware. Governor Cuomo says that 80% of the people in New York who are put on ventilators do not come off ventilators. Some reports are saying 88% of the people on ventilators. And then you remember we did one of your podcasts talking about the hyaline membrane disease and the hemorrhages caused by that. My main point that I am making is that we have to focus much more on the patient's own tissues and relatively less on the virus, because we have no really clear direction. We don't have a vaccine for Ebola virus so far. We don't have a vaccine for SARS virus. We always talk about the smallpox and polio as examples of viruses which vaccines which really eradicated those two diseases. So we know that vaccines have great potential. But I think we need to focus more. And the other thing is the thing that I'm talking about, people do that themselves. These are ordinary things. If somebody has diabetes, and let's say he was not as careful as he could have been to control his diabetes, okay, and not get into complications of diabetes, dialysis, dementia, that sort of thing. But the COVID-19 put the fear of God in his head. So with all this information, program like the present program, your program, television, radio, doctors concerned, so there's more awareness. And somewhere along the idea goes that what is making me vulnerable to the virus is my diabetes. But if I, for this reason, not to fall victim to the COVID virus, if I'm taking care of that diabetes, then it's also preventing damage to my brain, which diabetes causes. It is preventing damage to the liver, which diabetes causes. It is also preventing damage to my kidneys, which the diabetes causes. So the patient is now empowered with knowledge of what his contribution, her contribution can be. I think it's a win-win situation. People are better informed. They can be better informed. They're more motivated. I will tell you from my experience that whenever a person who is not in good health has this information, that is something I can do, which could be teas, which could be herbs, which could be spices. There are so many. After all, we have coexisted with these plants for a long time. We have coexisted with these microbes for a long time. And our ancestors, some of them were very insightful. And they did test these remedies. And the difference now is that we are testing the remedies in a much more systematic way and so-called much more scientific way than in the past. So I think our confidence is growing. I just gave you an example that in New York City and metropolitan New York, the two worst hit areas in the world by COVID-19, for a medical practice to say that we've had patients who were COVID positive, we've had a lot of patients who had viral symptoms, but the test was not done or the test was not positive. Not one of them needed to be hospitalized, and they did this work themselves. I think this is a great tribute and a great source of hope that we are not so helpless against the virus as some of the statistics might project.
Going back to something you said earlier about healthcare is a matter of personal responsibility in people.
Yes.
And, this is a free country. You have control of what's been put, what gets put into your body and your own healthcare. That's all well and good, but there's many people out there claiming that their healthcare is their personal responsibility, but also refusing to honor the social distancing rules, the mask wearing rules. It's come down to a number of confrontations we've seen around the country. So what do you say to the people who aren't really taking it, crowding beaches, crowding bars? They don't have a fear of God of the coronavirus, or they're not taking it seriously. They think they're being lied to. What would you say to them?
Much can be said positively for social distancing. It's hard for me to find out what can be truly a negative thing about social distancing. Richard, I went to Western Mountain, Mountain State Camp. It's a very large park, about 2 hours from New York. And that day, the sun was up, the mountains were beautiful, and there were a lot of families with children, small children, intermediate children, teenagers. They were picnicking there. And this was when we were being told that don't go to Central Park in New York because there are too many people and you can't do social distancing, even in Central Park. I spent a whole day and I was thinking how cruel and unnecessary and uninformed it would have been if the governor had said that nobody can go to Bear Mountain State Park. And it is a massive park. There are 7 large lakes in it. Now, there is where I live on 73rd Street in Manhattan, they built a park type of a thing. It's a little extension, a bridge, so to speak, not a complete bridge, on River Hudson. So people could take their dogs there, they go there, the runners go there. And so when the sun is up and those people are enjoying themselves, I think it is difficult to make an argument because the virus is most dangerous when they are in close quarters. Okay. Now coming back to the mask, I wear a mask regularly, more so because I'm sensitive to other people who are walking the same street. So as a physician, even though it is confining somewhat, um, but I still wear that. It's my symbolic gesture that you are wearing it because you may have some more stronger reason that I'm wearing, but I am empathizing with you. Okay, so I think those things, mask wearing and social distancing, are very reasonable things to do. But if you have those circumstances where it's a large, massive area of open space at a very nice day, and it is a breezy day, and there is social distancing of 50 feet or 50 yards if you want to, then I think then we should be open to that.
Should people know that the second wave of this virus could be potentially worse than the first wave?
I think number one, that fact scientifically would be very, very easy to defend. All you have to do is to look at the past records, the flu, SARS type of this, Ebola type of situation. So you know that you never really eradicate. These viruses are ultra microscopic structures. They invade our immune systems and they actually use our immune cells uh, as their resident cells. So I cannot conceive that the next winter, when we could expect the next seasonal flu, that there would not be mixing of COVID-19 with those viruses. So I think it's a given that there's going to be mixing. and mixing would create mixed patterns of clinical disease. So that is actually, in my mind, a very strong reason. Because if you took this situation that we are going to focus only on the virus and leave the patient's own tissues, my own body organs out of the picture, there is a great advantage in looking at this, that we have coexisted with these flu viruses all this time because there were multiple of them, and they would come back next year and the year after that and the year after that. So by focusing on our own self, there will be less fear. There is more sense of personal participation by the patient. By the way, a physician like myself, I was on the other side. I did my surgical boards in London, 1960, whatever, 67, 68, at that period of time. And then I did my boards in surgical pathology, clinical pathology. I think I do understand the mind of the physician body quite well. I think that I've been in clinicians now, full-time clinician for the last about 12 years, doing integrated medicine, which means combine what is good for the patient. It could be technology, it could be surgical procedures, it could be natural therapies, indigenous therapies, and actually it could be faith healing. But faith healing practiced by a person for himself or herself. I make a distinction when somebody promises to faith heal another person and somebody who wants to surrender to his own higher being, or own higher being, and try to allow that faith of his ancestors or her ancestors carry the healing power of that. So I am very, very impressed by that for the patient. So I see a lot of those things as good. I'm an optimist. I think that the message of COVID-19 is not going to be as neglected as Spanish flu of 1918, which killed many more people. But that time there was no television, there was no radio, there was no communication. Just like Bin Laden's legacy is that all of us have to take the shoes off at the airport, and it delays us so much time. I believe that if we are not careful, the legacy of COVID-19 is going to be, there's going to be a terror. Every time the weather changes, every time somebody has some sniffles, every time somebody's neighbor has a viral symptoms, they may have a temperature, that's very common. So I can see a large potential for hurt, but that's only because we are not focusing on education. I believe in education.
We want to remind everybody that the best information about strengthening your body's natural defenses can be found on Dr. Majid Ali's website. A good place to start is the Ali Academy website, which is majidalimd.me. That's MAJIDALIMD.me. MajidAliMD.me. And of course, you can find the podcast. Just go to Podomatic and search Majid Ali, and you can see Science, Health, and Healing every Saturday evening at 9 p.m. on Manhattan Neighborhood Network on MNN3. Dr. Ali, thank you so much for giving us all this good information tonight.
I am honored that you asked me to join you in this program, in this worthy work. I'm very happy as a friend that we spent this hour together. And it is an important subject. And I do believe that this kind of education can reach a lot of people. And there would be a critical mass of people who are well informed. And so we will not be so vulnerable to shortcuts in data processing or the data presentation or building your model. How about if we also bring discussion on what these models are and what are the people who have difficulty with these models? What do they say about them? You know, there are some people. The world's most prestigious journal is a journal called Nature, and it had a seminar type of essays. Different people contributed, and they are saying that what is called clinical significance of the medical that should be eliminated. You know what that is? That those p values that we have used for generation to show that there is statistical significance of what we are saying. The people in the highest level of science, they are saying, no, it causes more misunderstanding and incomplete information. So I think the more we know, the more we want to know. So I'm optimistic in that way. I think knowledge can cut down the panic reactions tremendously. Faith can cut down panic reactions tremendously. And support from our family members, our friends, all those things are crucial in this.